as we think about, if you're really serious about making America healthy, having access to basic services and basic care and prevention is going to be really critical. And these numbers, and particularly, across different by race and ethnicity, point to the need to really think about addressing some of these deep disparities.
Yeah. So if you're in Nebraska and you're not spending any money on healthcare per capita and you're championing that fact, but 50% of your Hispanics don't have a primary care doctor, and you're New York and you're overspending, and we're not really talking about it. There's a lot here. There's a wide variance in who's getting healthcare and who isn't. All right, we're back with Liz Fowler for round two. For anyone who doesn't recall, Liz is the former director of CMMI, the CMS Innovation Lab, was instrumental over the past few years in pushing forward a lot of ACOs, value-based care, alternative reimbursement models. And what we're going to do is explore state-by-state performance in healthcare across the US to see who's doing what and how they're performing. And I think that we're going to be asking a lot of questions. Don't necessarily have all the answers here, but at least we're diving into an important topic. So I'm going to start sharing documents that we can delve into. Here's the first one. So this one is interesting. We won't spend too much time on it other than to say that ChatGPT doesn't have an answer for everything. Not yet. So when you ask ChatGPT to compare state by state healthcare performance across, I think, 50 states at this point, and you ask for comparisons in actual approach to healthcare by state, I've highlighted this in yellow, and then you ask for the key metrics that you find interesting. In my case, it was ranking health systems, health outcomes, insurance coverage, healthcare spend as a percentage of GDP, readmission rates to hospitals, cancer survival rates, average wait times, nurses per 1,000 populace, and beds per 1,000 populace. You expect to get really good intelligence. And this Excel spreadsheet came straight from ChatGPT, except you discover a few things. One, it takes ChatGPT about 2 to 3 days to process this request. So you have to leave your computer on and ChatGPT keeps telling you it's working on it. And two, the actual metrics that you get, you don't believe. So when I actually sort by any one of these columns, I don't actually think the numbers are accurate. So we're not quite there yet. And everyone who uses ChatGPT, Liz, knows that half the time, the numerical responses are a little wonky and you sort of have to go back and forth and say, well, this doesn't make sense. And then ChatGPT apologizes and then it refreshes and then things make more. I don't want to do that with all these numbers. So it's not actually usable, in my opinion, except for it raises the question. Well, it shows what we're hoping to be able to get to, which is a very easy, fluid resource for just ranking state performance. We're not quite there yet, but it does do something I found particularly interesting. It has these 4 different categories for how states approach healthcare. And so I just thought that was interesting to start there with you, Liz. So here's category A, all payer rate setting, global budgets, which suggests to me that this is sort of a Maryland approach to healthcare, not that Maryland is listed here, but states that like to dictate pricing to all hospitals and all providers, and they don't necessarily allow variance in pricing. And they have sort of a capped budget for healthcare, especially as it pertains to Medicaid, but maybe beyond that. And so I'll start there. Does this category mean anything to you when you look at it? All payer rate setting, global budgets.
So, first of all, thanks for having me back. Appreciate it and glad to be here. It's an interesting topic, and I can't say I am an expert on these areas. But second of all, I would say I'm not sure what we saw last week from ChatGPT in its help writing the White House HHS Make America Healthy Again report, where there were a lot of errors and it was clear that ChatGPT was pulling information that wasn't accurate. You have to look very closely at what it sends and all of the data, and you have to make sure that it's that it's accurate and valid. And I'm not quite sure what it means by all payer rate setting and global budgets, and especially since Maryland isn't there. So highly skeptical of what you have here.
Yes. All right. So next category, heavy ACO integration and state oversight. So heavy ACO integration makes sense to me, at least linguistically. I know what it's trying to say. So I guess framing the question for you, do you think in terms of, because I think of heavy ACO adoption, and they have that term here. And the first states I think of are, let's see if they have them. No, heavy ACO integration, Florida. Yeah, I think of Florida. I think of, let me bold Florida. I think of California.
I mean, is it heavy ACO on the commercial side and the Medicare side? Probably not on the Medicaid side. What does that mean? And what does state oversight mean in
You
context of
you
ACO?
think there would be state oversight everywhere? I'd like to think
Well,
so. Let's start with you. When you think about ACOs, right, coordinated care, and you think about the ACO movement, about, I don't know, 1,000 ACOs functioning across the US, some larger than others. And yes, you think about different ACOs for different payer programs, coordination of care for Medicaid versus coordination of care for commercial. Do you think of it as different degrees of penetration depending on which state we're talking about? Like, I don't see a lot of ACO penetration in New York. So, how do you think of it?
I mean, I guess the way that we were measuring at the CMS Innovation Center was thinking about the proportion of traditional Medicare beneficiaries who were aligned to an ACO. And that's how we thought about it. And so we compared it, and that's going to vary. I mean, in some states, Medicare Advantage has a high penetration, and the traditional Medicare proportion of the population is already sort of less than half. In some states, substantially less than half. And so of that remaining portion, what proportion are in an accountable care organization? And so we were looking at that and actually working with our colleagues at the Assistant Secretary for Planning and Evaluation in HHS. It's an office that has been now reduced by about 70% by DOGE, or maybe 80% by DOGE, but they were doing some interesting work looking in to see whether or not high levels of ACO participation or alignment was associated with lower Medicare spending. And they were finding that there was an association. I think you're looking at it a little differently here. And again, I'm a little confused with what Chat GPT has come up with.
Yeah, look, I interact with every state and in my own small way, and I do see a difference in approach to healthcare from heavy ACO adoption states like Florida, with a heavy emphasis on coordinated treatment plans through primary care hub and spoke models that are ACO integrated and think in terms of capitated rates, PM per member per month, and risk, right? Upside downside risk. And so they sort of have migrated to think about healthcare the way an insurance company would think about healthcare.
Tools of a health insurance company. For example, ACOs right now, they can't use prior authorization. There's no limitation on where you can go for a provider. And so I think this is actually a point of dispute. Some people look at ACOs and say, oh, that's like HMO light. It's really not quite the same thing. I think HMOs would like to have some of those tools, but that's not how it works today. And also, I think another thing that's important to mention is we want to make sure it's not just about the spending, but we also want to look at the outcomes. And I don't see in the measures that you're showing on the screen anything about quality improvement or access to care to make sure that people can get in to see a doctor when they want, or that they feel like their doctor listens to them, or other measures of sort of patient centered metrics related to quality of care outcomes.
Yeah, no, this is ChatGPT's botched attempt. So we're going to shift into better sources. They still exist, better than ChatGPT in a second, but just still trying to frame the paradigms, right? For now. Let's delve deeper into what you just said. I found it very interesting. So I'm not sure that a lot of people understand the nuanced differences between managed care and an ACO, right? So how would we highlight those differences to them? So in both cases, you're looking at an entity who's tasked with coordinating care treatment plans, structuring a network, solving for outcome on behalf of, say, the payer, whoever the payer might be, but still different. How would we highlight those differences?
I mean, I think some of the more important differences, again, as I think about it in the Medicare context, and I think it, an accountable care organization is accountable for the cost of care and the quality of care provided. They are given certain tools and the ability to coordinate. They have data that lets them know when to stratify their patients and know who might be at higher risk for hospitalization or rehospitalization, who needs to make sure that they're getting their preventive services. They have the ability to coordinate with specialists that patient may need. They have the ability to offer like a 24-hour, 24/7 nurse line, or a helpline where somebody at the other end has access to their records and can help guide them when a patient calls in for help. These are sort of the patient-centric aspects that I think of for accountable care. In some cases, they may be capitated for primary care or some set of services. but for the most part, it's not necessarily capitated in the same way that you think of a per capita cost or a capitation amount for managed care for an HMO.
Yeah, when I ask ChatGPT, it sort of reminds me of that nuance. Difference is who the master is, right? Managed care, your master is the payer. Your business model is about selling to the payer your services, which is interesting because all of healthcare involves convincing the payer, right? ACOs, your focus is really on the provider. The provider is running or is viewed as the leader of the ACO, and so the decision maker, and so the structure of an ACO is considered provider led. But at the end of the day, they both work with cost containment, cost management, quality control, network organization. So they have a lot of similarities. Would you agree with that?
I think for the most part, I don't know about the network part because in an ACO, you can't restrict the networks. You can't say you can't go to XYZ hospital. They're not in the network. At least under Medicare and fee for service, you still have the right and the ability to access any provider. You hope to be able to guide those choices, but ultimately you can't say, no, Medicare's not going to pay for it if you go to that hospital that you don't think they should go to and you'd prefer they go elsewhere.
Okay. So finishing off on this list.
It's mandatory coverage.
Yeah, so mandatory coverage seems interesting to me because the first state I think of when I think of more aggressive coverage or tools to drive coverage is Massachusetts, right? The Romney approach to medicine, which he implemented, I don't know, about 20 years ago, which led to ACA, right? But they don't reference Massachusetts here. So we'll get into in a second.
But they mentioned Michigan and Utah, so I still can't believe it took ChatGPT 2 to 3
2
days.
days, yes. But I do think they're at least right in saying that some states have pushed coverage a lot more aggressively than others in their policy. So I think Massachusetts coverage is up north of 95%, whereas the rest of the country averages at 90%. So there are differences. So I applaud them for that. I just don't think they've listed them accurately. Any thoughts on mandatory coverage?
Again, not sure what they mean. And as I look at this list, what I think of is, and this came up the last time we had a conversation, the Commonwealth Fund has a report, a state-based scorecard that ranks states based on performance, that has metrics that they've outlined in terms of state performance, and they've ranked states. But those metrics are things like access and affordability, premature death. I think there's cost measures as well. They also look at reproductive care and women's health, but they have an approach that I think may be better and more scientifically valid than.
For sure. We're going to go to the Commonwealth Fund in this chat. So we're going to go there. You're a bigger fan than me. You and I have spoken about this.
Yes.
I'm not shall we say this way? I'm not a huge fan of the Commonwealth report. I've said it before. And I certainly don't think that I haven't seen any report that easily compares different approaches to healthcare by state. So actually, as bad as inaccurate as this is, at least it exists, is sort of one thing that I would say, publicly and somewhat easily available. So it's sort of garbage in, garbage out, but at least you have the garbage. So we'll get there. We'll get to the common.
But you're not sure what the garbage in was. Like I can't really tell.
No, it's true. Another theme that they're at least exploring is Medicaid expansion, which we hear referenced anecdotally all the time, but we don't actually think about it structurally and analytically. Yes, there are some states that are far deeper in Medicaid and spend on Medicaid and access to Medicaid than others. And I think we also saw that in the reaction to ACA, where some states worked with ACA to expand Medicaid and others didn't. And it's all coming to a head now, 15 years later, with the administration currently making it a lot more difficult to continue on that Medicaid expansion path. And so I think we're going to see potentially meaningful Medicaid contraction. But it's interesting that the variance exists across states when it comes to Medicaid. Your thoughts?
Well, I think, first of all, the Affordable Care Act envisioned that Medicaid expansion would happen across all 50 states. But there was a Supreme Court decision that came out in 2012 that made it an option. And so that's why you have some states that still haven't expanded and many that have. And first of all, I think the states that have expanded do a lot better job at making care affordable for the lowest income. Make it more accessible. ChatGPT has paired it with ACO adoption. I'm not sure what the connection is between those two things.
I'm not either. Actually, I think of Medicaid expansion as typically a blue state versus red state topic, with the blues expanding, the reds not so much. But I don't want to guess at it. That's where having these reports can be so helpful.
Some states have expanded through ballot initiative, and I think what we've seen is that people want access to healthcare, and they if given the choice, they would opt for the state to provide that assistance. And I think what we see in Congress now, with the bill pending for passing in the House and now up for debate in the Senate, is the potential to really undermine coverage in not just blue states, but across the board, by applying work requirements to Medicaid. And I think
There's a lot going on, and there's certainly risk that people push, as they have in the past, in certain directions without having all the facts. And ChatGPT is not helping. And last category, private insurance dominant, limited public system. This seems like a genuine category to me. I just don't think they've assigned the right states. Like, I don't think Massachusetts is private insurance dominant, but at least I do believe that the category exists. Any last thoughts before we leave this analysis behind?
again, I don't know what that means. I mean, Medicaid, for example, a lot of coverage is provided through managed care organizations. So many states rely on managed care for their Medicaid populations. Private insurance dominant could be the proportion of Medicare that's in a Medicare Advantage plan. So there's a lot of nuances, even within public programs, who's covered in sort of a more of traditional sort of public coverage versus enrolled in private options through public programs.
Yeah, so this hybrid model, outsourced. So Centene, I'll stop here, but Centene is the largest Medicaid insurance provider or carrier in the country. The funding is state and federal, but it's still a private insurance company. So what category does it fall under? Right? It's a little bit of both.
But that's where, again, ChatGPT doesn't tell us what they're measuring, and that's why I think it's really hard to read what they've come up with.
Okay, so there's still hope for analysts in this world.
I turn back to the Commonwealth Fund, which I know you don't.
Hold on, hold on. Before we go to Commonwealth, let's go here. Let's go to my favorite. So I do have a favorite. Sorry. Okay, so this is Kaiser. This is the Kaiser Foundation, and this is publicly available to all of us. You just have to go to the Kaiser Foundation website, and you can customize your own report by state based on a whole slew of metrics. You can't make them up. There are a finite list of options, but it's quite a long list. And I simply picked the categories that I find interesting. And here we have accurate data. Yay. And we have it in a way that adds value. Yay. What they didn't give me is an option to compare states by approach, by policy approach. So that's gone. That's one of the reasons why I still held on to ChatGPT, because I find it useful. But it did give me some hard facts in response to some hard questions. So let's dive in, if you're willing. And then we'll end with Commonwealth. So here we have the US, and then I've highlighted in yellow certain states that I think, like Florida, like Illinois, like Massachusetts, New York, that I think Texas are very large and sort of trend setting. But in truth, every one of these states is interesting. And where I've seen interesting data points, like over here in Maryland, I've bolded. So first question, growth in private in health insurance spending per capita. So this is sort of a measure of spend in healthcare. And if we've seen an annual growth of 4.5% across the entire US over the last, it's not the last 25 years, it's a 20-year period between 2001 and 2020. It's interesting to note that California, with all of its, and this is per capita, this takes into account population growth. So this is an increase per individual. So California, with all of its ACOs, and it has as many, I think, as Florida or more, and all of its attempts at cost containment, has actually grown faster than the US by a considerable amount, north of 10% faster per annum, faster than Florida, faster than Illinois, who everyone thinks is, a little less cost orientated based on the news. Interesting that Maine has kept up with California in terms of cost. So California, faster than New York, seems to have a cost containment problem, only beaten by Tennessee, at least according to Kaiser.
So I guess one question is whether those differences are statistically significant. And then do they account for example, if a state did expand Medicaid in that period, which they would have, and the generosity of that coverage, some of those factors may make a difference. And so looking at the raw numbers can be interesting, but I would want to dig
I think that's a very helpful response. Liars lie and statistics lie even more. I think I butchered that idiom, but there's a lot of truth to it. So yeah, California has a very high Medicaid population, and the expansion of it is going to be inflationary. So that's interesting. Some states, and this is a theme that will come up again and again, different states have a very different challenge when it comes to healthcare. Some are dealing with a lot of Medicaid, some are dealing with a lot of obesity, some are dealing with a different age concentration, right? Older demographics. It's not like they're all dealing with the same set of facts on the ground. Private percent of adults who are overweight or obese. Speaking of which, so 65% across the US. I always bring up Japan, which is at 5%. Again, this is according to Kaiser. Alabama, 70%. California, 60. So a spread of 10% between Alabama and California. And then we run across Iowa, 70. If you did a sort of means test by region, you'd find the southern states consistently higher than the US average. Louisiana, a good example, at 70. And then back to the northern states, Massachusetts down at 61. California at 60, New York at 61, Texas back up to near 70, West Virginia 71. So you're dealing with, as I like to simplify it, basically two different countries when it comes to obesity. Way below average and way above average. We seem to be quite bipolar. The differences are enormous. The variance is extremely wide as I look at it. The difference between a 70% and a 60% is high impact on healthcare infrastructure. That's not like one or two extra patients. That's a lot of burden. Any thoughts on obesity? And I think drug overdose, and this brings us back to how a lot of these other reports tend to focus, Commonwealth being one. A lot of the focus is on outcome and quality of life. So drug, obesity, suicide, those things are measured constantly and spoken about by our media constantly. Less so hospital readmission rates, nurse staffing ratios, which I think are less exciting for our journalists to cover. But for me, arguably more important in terms of understanding investment in healthcare. But this does tell a story that there's very different demographic behavior going on across the country. If the United States drug overdose death rate is 32.6 per 100,000 across the country, and then you have California at 26, and you have District of Columbia at 64, that's two very different worlds.
Yeah, I'm not sure what's going on with the district number, but there has to be some sort of explanation. That seems...
Well, you've got some other states that are close, right? Kentucky, Louisiana, Maine. I wonder what... So I'm surprised by Alaska's numbers. And then you've got Minnesota at 24, Montana at 19, Nebraska at 11, although Nebraska's tiny population, so I think statistically less relevant. So again, very wide variance here in numbers and very different strains on healthcare, right? Emergency room strain. Back to healthcare expenditures, this is not an annualized average over 20 years. This is just looking at 2020 was the last number, the last year they gave me, which was a little stale for Kaiser. So I'm not sure why they're capping this at 2020. You'd think they'd update it. United States, $10,000 average spend per individual per year. California, in line. Connecticut, high. District of Columbia, 40% higher. So extreme variance there. Florida, low. Illinois, average. Maryland, who I thought would outperform here with fixed pricing, set pricing. They don't need transparency. They only have one price across all their hospitals, right? For any claim, it's the same price.
So it includes all payers, and they're not doing so badly then. So they're right, I guess, in the average, as in
Maryland.
Right.
Yeah, but I would think with more control over pricing, the state could set pricing in such a way that it would outperform here on spend. But I guess to your point, there's many other considerations, right? Is their demographic just more expensive to provide care for?
And the Maryland model, in its new iteration, will set spending targets and along with the hospital global budgets.
Yeah, so maybe they're doing the best they can with what they have. Yeah, it's not definitive. It's just suggestive, I would say, this data. Massachusetts was a surprise to me. But if you think about it, maybe not a surprise. If you're going to maximize coverage, are you maximizing spend as well? Do the two go hand in hand or not necessarily? But a 30% higher spend per capita than the rest of the country was a surprise to me in Massachusetts. Any thoughts? And then New York, not a surprise. I know that New York makes a point of spending a great deal in every regard, and different arguments thrown at New York for why that is. Constrained competition, right? Limited competition amongst payers, and a lot of population demographic complexity, high Medicaid percentage, focus on access, unionized workforce, heavy hospital reliance, inpatient
Right.
reliance.
I think the heavy hospital reliance and the sort of like how is primary care organized and delivered, and what proportion of providers or what proportion of spending does primary care represent? I would want to know. I would want to know a little bit more about some of these numbers.
Yeah. And then Texas, by comparison to New York, almost 50% less spend per capita. So if I'm in DC and New York shows up and says, we need a bailout, our budget is problematic, we need help, I would say, why don't you start with this? 14,000 per capita versus 8. And then I would hear all the reasons why from the New York representatives, why you can't blame New York for spending almost 50% more than Texas does per capita on healthcare. But it is quite amazing that the spread is as wide as it is. Any thoughts on Texas?
I mean, Texas hasn't expanded Medicaid. I think access is an issue there. They have a very high proportion, one of the highest proportions in the country of uninsured. I think there's so much behind these numbers that
So access, just constrained access drives down cost, which we know looking at Europe. Okay. So we sort of have our Europe versus US comparisons happening here in the US. Access versus lack of access and the impact that it has. Inpatient.
But Roy, I think there's a difference in the way that access and care is sort of arrayed across a population in Europe, in a lot of the countries. So think about the UK, for example. Everyone has access to coverage. You might not get the best, most expensive, newest thing all the time, but everybody has access to basic care.
You're being too kind as a European. You're being way too kind. The
No,
definition
I
of access,
understand the
it's not if you're
limitation.
waiting 3 years to get treatment. It's
I
not access.
understand, and I understand, but I also think there is something to be said for everyone has access to basic care.
Yeah, yeah. It's the right way of saying that eludes, I think, both of us. There are arguments in both directions that are really strong. Over reliance on the word access, it's like, I don't know. Lots of people use lots of headings, but when you get into the actual meat, the actual substance, it's just a heading. So we're just saying the same thing. You can't rely on any one data.
Right.
Totally.
It's sort of how do you decide to ration? Like, I don't think people in this country would tolerate a waiting list for a hip replacement or a knee replacement that long. I just don't think that they.
They wouldn't tolerate a 3-year waiting list.
No, but well, some people actually probably do, or they don't have access at all because
Yeah.
they can't afford it or they're uninsured. So
Yeah. Yeah.
I mean,
Healthcare is hard everywhere. It's not easy. It's not easy to take care of everyone.
I think also you can read into the numbers the story that you want to tell, and I think you just have to be really careful exactly what you're looking at and the reasons behind that, and control for other factors that maybe are impacting this, the numbers, and may undermine the theory that you want to create. And so I just think you have to just be a little bit careful.
Sure. But it's not going to dissuade you and me from digging into the numbers nonetheless.
True.
We are brave sailors here, sailing straight into the hurricane. So inpatient spend per day, hospital inpatient spend. So California, about 20 to 30% higher than the US. I'll come back to why I think that's not a surprise to me. Florida, slightly below. Illinois, about perfect, about average.
Then wouldn't you want to know the sort of the concentration of hospitals? People are looking at competition and all the integration now. Like, there's so many factors that go into this, and just looking at a single number isn't necessarily going to be able to explain a lot of the underlying causes and factors.
Yeah, look, I'll give you one cause: cost of living and average wage, right? So California is a more expensive place than Wyoming.
Yeah.
Everything. So you'd expect that most people are going to get paid more to do the same work, same value in California versus Wyoming. Houses cost more, schools cost more, most things cost more. Maybe TV screens don't, but having the TV screen, I guess, shipped to your doorstep might cost more. So the realities of doing business in California and providing any service in California is that it's going to cost more than Wyoming. Having said that, California inpatient care costs more than New York. And I'm not sure that the average wage across the entire state of California is higher than it is in New York. I'm not sure. This is sort of a Big Mac index approach to healthcare, a purchasing power parity approach to healthcare. And if New York and California have the same costs of living, and now one is spending significantly more on inpatient care than the other, it begs the question, is there less competition amongst health systems in California versus New York? And we have to use the same rules that journalists use when it comes to private equity and market manipulation amongst businessmen when it comes to hospital administration. Does less hospital administration equals more monopolistic pricing? And so any one of these data points necessitates what we said at the beginning of the podcast, more analysis, but it is interesting. Yeah.
Fair.
Market dynamics measured across states.
Look at market dynamics. Did you consider some of those factors in what you've collected?
What do you mean?
Number of insurers or consolidation of providers,
Oh,
some of those factors.
I mean, they sound really interesting. They're not in this report.
Okay.
Yeah. This report I spun up in one afternoon.
Faster than Chat GPT, I might add.
Yeah. Well, this one, at least, Kaiser is full of value. So I'm very grateful that they have this option available to all of us. We should all be playing around with it. But again, it's not a substitute for really digging deeply into this topic and coming out the other end. And I think this is one of the reasons why we need public health schools, academia. So, we were on the phone with John McDonough from the Chan School of Public Health in Harvard. We're speaking with the Yale Public Health School. I've spent time as a semi-adjunct teaching at the Mailman School at Columbia, getting to know what these public health schools actually do. And I think they represent us in digging deeply into these subjects and coming out the other end with real findings so we can adjust. Adults reporting not having a personal doctor by race and ethnicity. So now it's back to 2023. And what stood out for me is Hispanics versus everyone else. Not having a personal doctor, not seeing a doctor in the past 12 months, and this variance again between Hispanics and all the other groups, with maybe American Indians being second after Hispanics, was quite staggering. So no doctor, not seeing a doctor. California stood out for me as significantly better than the US average. And then Georgia, no doctor, 45% of Hispanics, just a staggering number. All adults haven't seen a doctor, and 15% of them in a year, past 12 months in Georgia. Talk about seeing a lack of access to healthcare manifested in a state. Iowa, 42%.
I mean, these disparities are really striking, and I think this just points to the need to continue focusing on reducing some of these disparities.
Yeah, I mean, 47% of the Hispanic population in Minnesota don't have a personal doctor.
As we think about, if you're really serious about making America healthy, having access to basic services and basic care and prevention is going to be really critical. And these numbers, and particularly, across different race and ethnicity, point to the need to really think about addressing some of these deep disparities.
Yeah. So if you're in Nebraska and you're not spending any money on healthcare per capita and you're championing that fact, but 50% of your Hispanics don't have a primary care doctor, and you're New York and you're overspending, but half that number don't have access versus Nebraska, you deserve recognition too. You're dealing with access to healthcare in ways that South Carolina is not. I mean, this 54% number is not a good number for South Carolina. And we're not really talking about it. There's a lot here. There's a wide variance in who's getting healthcare and who isn't.
Well, and I think this gets to the sort of the bottom line of the so what is then what are the public policy solutions? Which of these problems do you want to address? How do you want to tackle them? What are the solutions that and the tools and the levers that you have either in your authority and power today or in your budget today? Hopefully there's the political will to want to solve these problems. Sometimes I wonder whether that's the case, but.
Yeah, so if I had my wish list for journalists across America, I would say, get this table, put it on a newspaper, .com, and show access to care across states from one year to the next. How's everyone doing? And I think that's shining a light, as opposed to the distraction that we get on stuff that I don't think helps anyone, because I think it's misleading and I don't think it's helpful. America ranks last. Our life expectancy is too low. I just don't think that helps push the argument forward. I've given that statement a lot of thought. I just don't know what to do with it. Hospital beds per 1,000 population, hospital admissions per 1,000 population, hospital emergency room visits per 1,000 population. So that's a lot. Try to take them one at a time. Beds. Alabama, plenty. California, not that many, given the size of its population, but it's got a very large population. District of Columbia, very small population, lots of beds. So maybe we're seeing something there. Well, Florida, more beds than California. Illinois, more beds than California. So it is interesting that there seems to be a shortage of supply. New York, more than California. A consistent shortage of supply in California. Hospital admissions, average is 96 per 1,000 population. California, much lower. Less hospital care. Florida, plenty of hospital care, maybe too much. And what's the right amount? Illinois, consistently US average. Interesting. New York, way above average. So again, this theme of, so while we say that, Texas constrains supply, California is sending less people to hospital.
So maybe one question for you, Roy, as you look at these data, does it suggest that anyone is doing it right, or everyone has their own challenges and opportunities for improvement? And it's sort of like, what sort of nirvana are we trying to get to? What would be ideal? And I think,
that is such a great question. What we're missing is a column that says ideal, insert, and then another column that gives the reasons. And this would be way beyond this table, but at least a normative goal of what we're trying to be for all of this.
And what, because it's so muddled, isn't that why people look to other countries? Like, who's doing it right and what do we see in other countries? And I think we started getting at some of those questions in our previous conversation, like what, when you look at the international comparisons.
Yeah, I think that's one bridges to the other. You can't really understand any of these states without understanding all the other countries as well and what's happening there. CU beds, just to finish off on this table, guess what? We're going to see significant difference. Florida's at 3, California's at 2 per 10,000 population. So a difference of 30+% in ICU beds. So a consistent theme for California of undersupply. Who has less than California of the big states? Nobody. What is going on in California?
Well, I'm not going to speculate on that without knowing more about what questions we're asking.
Yeah. Short, interesting topic. We've got an average of 9.5%, which is we speak about regularly. Used to be 20, used to be 30. It's down to 9.5. California does better. Florida does much worse. Huge difference. 13.4%. Illinois normal. Massachusetts, there's the Romney Act. 3% uninsured right there.
Well, and that's what we were trying to get at with the Affordable Care Act, was trying to bring everybody down to,
And you did. You did right here.
Yeah.
Maybe not down to Romney 3, but that 9.5 it never used to be so low. So a lot changed. New York, 5.8. And then you get Texas, 18% uninsured. Another wow number.
Yeah.
Two different worlds.
The question is what the political will is to try to fix these problems too, and what the public is looking for. I mean, if there was an outrage, we want X, Y, or Z, and this is what the polling shows, maybe policymakers would respond. But I think there's a lot of frustration with healthcare, probably related to a lot of these issues, but there has to be.
They're just so buried, right? How often can you have a conversation like this where you're looking at an 18.6% uninsured rate for Texas, which is 100% higher, more than 100%, 150% higher than California. That's not a small gap. You're looking at an 16% Medicaid coverage ratio for Texas, which is 50% lower than California. It's not 50, it's 40% lower than California. Again, not a small difference. These are massive swings in approach to healthcare with huge implications. If you need Medicaid and you suddenly move from California to Texas, right? These are high impact differences. So it's just complicated, right? And who has time for it? I'll quickly show you two more. We'll end on Commonwealth because it's a lot. It's a lot for the two of us to get through. Key findings. This is health department website. This is sort of what I'm used to before the Kaiser pick your own. Drug deaths, cigarette use, uninsured, smoking, unemployment, birth rate, right? This is for US, and then they do the same thing. They look at the same stats: homicide, smoking, mental distress.
What source of data is this?
This is health department website, HHS. So I don't think this is helpful. I think it's cute. It's interesting to know on some level that in Illinois, they might be smoking less than in Kansas, food insecurity, diabetes, but I'd much rather go into the full depth of discussion on the many different comparisons, Medicaid coverage and so forth and so forth and so forth. I think you can only cover drug deaths and uninsured so much, right? There's just so much more that needs to be spoken about. And when you look at this, so much of this is just outcome and not input. Social and economic resources, education, physical environment, air, water quality. Okay, so I think it's just trying to do too much, right? Everything affects health outcomes, everything. Of course, water and air quality affect health outcomes, but I don't know that if you're going to summarize into an executive summary, 1 page per state, that I would grab all these huge topics, economic factors, physical environment, then clinical care, then behavioral, then health outcomes, and say we're done. And I'm in terms of access to information for the public. I think it's too much and it almost gets lost. Like who's doing what and how well. We're struggling just by focusing on clinical care. I'm trying to remove health outcomes because I don't think they're that helpful. Why is mortality higher in one state versus another? And I'm asking the input, the driving question, is one state underinvesting versus another? Don't give me the outcome, give me the input. And so I want you and me to just focus on differences in clinical care across states. And I'm going to completely ignore physical environment for the sake of argument, for the sake of academic study. I'm going to completely ignore these economic factors. And I'm just going to try to drill down on different states approaching clinical care differently. And so that's not happening here. Over here, we're just looking at everything and saying, and therefore drug deaths are higher. Like I don't see the logic tree over here.
I think some of these factors do impact.
They all impact.
And I think having those domains is really helpful, though. So grouping these measures together, considering what factors might play a role, looking at whether there's a difference in these numbers that might impact, for example, the drug deaths or mental distress or uninsured, I think is how you start to get at whether or not there's a policy solution when you start to see trends and you start to see connections. And I think that's where some of the work starts happening to think about how to address some of these problems.
I agree 100%. I just worry that because there's so many inputs driving healthcare outcomes, it's exactly what you said earlier. Anyone can sort of manufacture any argument they want when it comes to cause and effect. They can completely skip cause altogether and just deal with effect. That's self-evident. What I mean by that is we're bad because this stat, life expectancy, is bad. Insurance coverage is bad. That's not cause and effect. That's just effect. And then when it comes to cause and effect, anyone can say anything they want. This outcome is bad because of suicide rates. Well, this outcome is bad because of Medicaid coverage. Maybe, but I think the whole sleuth detective task here of what is the true cause for the true effect, the true outcome, is work that is very precise, and we need to be very careful about it. I will end with a reference to the Commonwealth Fund, because I promised you that, even though we're out of time. And I'll say, here it is. Health system scorecard, state level health system performance. And so things that stood out for me. This is just overall rankings, which maybe, I don't know what went into them. Premature women's health, access and affordability. Okay, these sound like very important considerations. And then let's see what they look at. Deaths from preventable causes. Okay, interesting.
So, Roy, I think what is relevant here is that you can see how they put these measures together and you can look at what went into these calculations. You can read how they've, the whole methodology. There's a whole methodology section. And so I think that level of transparency is really helpful when you're trying to draw conclusions, or when you don't agree with something, you can look back and maybe you would have done it differently, but at least you can tell how they've done it.
I totally agree with that transparency. I love it. What I don't understand is their lack of interest in cause versus effect in terms of clinical care. I don't need to focus too much on mental health. I don't need to focus too much on drug overdose for all the reasons that we covered. These are all important factors. They certainly speak to the different challenges that different states have in dealing with patients. Even reproductive mortality rates for women is more of an output than an input. Different degrees of access to care drive that. Different patient health stats drive that. Obesity levels are very important as well. Spend drives that. Patient hospital beds drives that. Nurse staffing ratios drive that. I don't think it's enough to say West Virginia mortality rates for women in reproductive ages much higher than Hawaii, therefore Hawaii's healthcare is much better. It's not enough.
But I think
This is an output.
But they have come up with a number of domains to look at these issues collectively in different domains, right? And I think it does come back to a level of investment in healthcare, placing a priority on coverage and access and affordability.
To your point, this is a great example of that. Access to prenatal care.
Right. So I think the investment in primary care is an important factor. The sort of commitment to expanding Medicaid and keeping coverage affordable, how much the state is willing to get involved and think about being more of an active purchaser, and in the way it runs its exchange may have a difference. So all of these factors, I think, are related.
Yeah, here they are highlighting Texas, uninsured, just like we just did from Kaiser. You see that?
Yep.
Okay, so look, there's a value in it too. Got to go through it. Spend more time. This was fun.
What is your bottom line for your audience? What would you want them to take away from this conversation? Just to look more fully at the data and become familiar, and people that care about healthcare should become sort of more invested at looking at these issues?
Yes, that's the takeaway. We're setting an example here. It's incredibly complex, but it's rich, and there's fruit on the vine. So we should all be picking away at it. Let's have this conversation again and again and again. How are our states performing versus each other? And when we're done and exhausted by that, let's infuse into that. How are our states performing versus other countries? When you think about it, many of our states could easily be countries. I'm not talking about states that have population sizes of 800,000, but New Jersey is a country. New Jersey is a country. They're all countries. We should be comparing them to many other countries, state by state.
They still operate within a system of regulations and coverage and cultures that is the United States.
Federation.
Right. Well,
thanks, Liz. I appreciate it.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.